Okay, so imagine you are a 47-year-old woman who's presented with a lower abdominal pain and you've been voiding more frequently. When I examine you, I found the anterior vaginal wall elicits severe pain. Palpation, when I palpate the anterior vaginal wall, elicits severe pain. So what's your diagnosis here? Like what's going on? You have frequency, urgency, dysuria, and the urinalysis is negative leukocyte esterase, negative nitrate. What is that?
Anterior vaginal wall will be, is it like a bladder, what do you call it? Systole?
So this is interstitial cystitis. So
Oh, okay. Okay, yeah.
even when you have the urinalysis negative, that's still interstitial nephritis. Don't let them trick you and throw you off by giving you a negative urinalysis. Okay, so this is called painful bladder syndrome, most common in women, associated with psychiatric disorder, anxiety, pain syndromes, and fibromyalgia. Clinical presentation present with a bladder pain with filling, relief with voiding, and increase of frequency, urgency, dyspareunia they have. How do you diagnose it? You have a bladder pain with no attributable cause for more than 6 weeks. Okay, so that's a big thing.
Okay.
With normal urinalysis, treatment not curative, focus on the quality of life. Okay, and you do behavioral modification and trigger avoidance treatment and amitriptyline, and you give them analgesics for exacerbation. Okay. Now the hyperkalemia. So if you have, I want you to tell me the potassium level from the EKG finding. So if you have a prolonged PR interval with a tall peak T wave, what's the level of potassium here?
With a top peak T wave,
Yeah,
I think maybe like a about 6.5 or greater than 6.5.
I love it. 6 to 7. How about if
Okay.
there is a loss of P wave with ST elevation and tall peak T wave? What's the level?
So about 7.
7 to 8, yeah. How about
Okay.
if there is a widened QRS and sine wave pattern, AV node block, and bundle branch blocks?
Of course, it's going to be higher. Greater than 8, right?
Yeah, greater than 8. Good job. Yeah. So okay. Now, if you are a 42-year-old male,
42-year-old.
yeah, who's unconscious in the subway station. So when I order the pH is 7.20, PO2 is 90, PaCO2 is 30, and HCO3 is 12. So how do you diagnose this acid-base status? What else is missing? What information that you need to know?
All right, so pH is 7.20. PCO2 is what?
30.
Dr. Ali?
30. Yeah.
Okay, and O2 is what? PO2?
90.
90?
Yeah.
Okay, there is no bicarb?
Bicarb is 12.
Oh, bicarb is 12. So this looks like a metabolic acidosis.
Yeah, so what is missing is that you need the anion gap. So you need the serum level of chloride and the other stuff, okay? Okay. Now, if you are, imagine you are a 33-year-old woman who had a schizophrenia, okay, who presented with a tonic-clonic seizure. When I order labs, I found the sodium is 118. Okay. So, and the serum osmolarity is 252, and the urine osmolarity is 78. So why the hell do you have this serum, this osmolarity values?
Is it psychogenic?
Yeah, it's a primary polydipsia. That's the thing. So so whenever you have a patient with hyponatremia, the first thing you look is the serum osmolarity. If it's more than 290, that's a hyperglycemia or advanced renal disease. If it's less than 290, then you look at the urine osmolarity. If it's less than 100, then you look at the urine sodium. But if it's if it's less than 100, that's a primary polydipsia, like we have this case, okay? But only if it is more than 100, then you look for the urine Na, and you look at it. If it's less than 25, then it's a volume depletion, congestive heart failure, or cirrhosis. But if it is more than 25, if it's less than 25, then it's sidage. But if it's more than 25, then it's volume depletion or CHF, okay?
Okay.
How about if you are a 43-year-old woman with a urine osmolarity of 250, plasma osmolarity of
Hold on.
326,
Urine osmolarity of 250.
yeah, and
Plasma
plasma osmolarity of 326, and sodium
326.
is 150. So
150.
yeah, so what medication causes that? And you have confusion and stuff like that. Use the bathroom more frequently.
Oh, maybe like things like sertraline, SSRI, carbamazepine.
No, this is not SIDH. SIDH have hyponatremia. This is called diabetes insipidus, caused by lithium.
Oh, shoot.
Because this is hypernatremia. It's called
Hyponatremia.
euvolemic.
Okay.
Yeah, euvolemic hypernatremia. Okay, so if you are a 50-year-old male uh, who have diabetes, so what are the glomerular pathologies that you expect here?
So it will be that what do you call it? Chemistine, whatever. That diabetic, something about sclerosis and basement, glomerular basement thickening,
Yeah,
right?
first you have glomerular hyperfiltration, and then you thickening, and then expansion, and then nodular sclerosis.
Mm-hmm.
Yeah.
Chemistine or
Yeah.
chemistine.
Now, for RB red blood cell transfusion threshold,
Red blood cell.
yeah, if it's less than 7, always indicated. But what if it's 7 to 8? At what are the indication of transfusion in this case?
Is it the ones with heart issues?
Yeah, if someone taking cardiac surgery, heart failure,
Mm-hmm.
or
Mm-hmm.
oncology patient in treatment, if you have the hemoglobin 7.5, then you gotta transfuse them. How about
Mm-hmm.
at what condition we transfuse at 8.5 hemoglobin?
Oh, is it like when they are having like I don't know? Is it like symptomatic? I don't know.
Yeah, when it's symptomatic anemia, or when you have ongoing bleeding, hematemesis or
Mm-hmm.
something like that, or when you
Hemorrhagic,
have non-cardiac surgery or acute coronary syndrome.
acute coronary syndrome. Sure, yeah, it makes sense.
Okay. Now, if you are a 50-year-old male who present with polyuria and polydipsia, and your sodium is 140, potassium is 4, and when you get referred to ophthalmologist, you will be screened for diabetic retinopathy. So what is the most sensitive screen for nephropathy in diabetes?
On is that something spots uh, protein something spots, or you can do the protein creatinine ratio.
Excellent. Microalbumin over creatinine ratio. Random urine for microalbumin over creatinine ratio. Okay, so if you are a 58-year-old male
Mm-hmm.
with a decompensated liver cirrhosis and ascites,
Hi.
hi, hi, welcome, Sahar. Sahar, you're here on board? Okay, welcome. Okay, let's continue. We're just doing renal right now, the first part of renal. Okay, so that's what we're continuing. Okay, so imagine you are a 58-year-old male who was diagnosed with a decompensated liver cirrhosis and ascites. Okay, so you get admitted. So at the day of admission, your serum chloride is 101 and your bicarbonate is 19. But 3 days after, the bicarbonate is 31 and the chloride is 92. And the creatinine increased 3 days after. So what medication is causing these problems?
Okay.
So that's what
So
I mean.
before,
When you have decompensated cirrhosis, we usually give them sort of medication. One of the side effects of that medication, you have metabolic alkalosis picture and worsen the renal function. So what medication that caused that?
metabolic alkalosis.
Mm.
Are you talking about maybe diuretics?
Which one?
Furosemide?
Excellent. Yeah, it's a loop diuretics. If furosemide, it can cause hypokalemia, metabolic alkalosis, and pre-renal kidney injury.
Mm-hmm.
Okay, so it's a very interesting question.
Yeah,
I like this question. And
you like
they
it.
can only give you the bicarbonate's been increased. Yeah,
Mm.
because you know the mechanism behind it, right? Obviously,
Mm-hmm.
it's gonna cause that. Okay, now if you are 25-year-old woman with a frequency urgency dysuria, when I examine you, I found suprapubic tenderness. Leukocyte esterase is positive and nitrate is positive. So how can I treat you?
Okay, any allergies?
No.
Okay, so you can do SM, what do you call it? Bactrim. I always call it Bactrim. Or you can do nitrofurantoin.
Okay, what else?
Or you can do third generation cephalosporin,
Hmm. Yeah, you
right?
can do
So
that.
this is like a simple cystitis, yeah.
Yeah, or fosfomycin. Okay, you can single dose. You can
Fosfomycin.
do that. Yeah, single. How about if the treatment failed? What do you do? What's the best next step?
I guess you can now do like fluoroquinolone. I don't.
Yeah, if that didn't work. How about if the fluoroquinolone didn't work?
So what else can you give?
Then you do urine culture.
Oh, okay, 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 okay,
Okay, that's the
okay.
indication for urine culture. So you never order urine culture on these patients, but if the antibiotic failed, then you do urine culture just to see what the hell is going on.
Sure.
Okay, what bug is causing this problem, and then you treat it. So how about how about if someone have cystitis with diabetes?
So
Then
that
how
would
do
be
you?
complicated.
Yeah,
So that would be complicated cystitis.
yeah. So how do you treat that?
Like you give them fluoroquinolones, right?
Yeah, you give them.
And then you do culture also
Yeah, you do flora. You do culture initially. Okay,
before you
and
start the
yeah,
antibiotics.
yeah,
Okay.
and then you give either fluoroquinolone for 5 to 14 days. You give them that. How about if the fluoroquinolone didn't work?
What else can you give them?
Ampicillin, gentamicin.
Sure, yeah.
Okay, how about if so this is called complicated cystitis, you're right. Other condition that considered to be complicated cystitis, if the patient is pregnant, having renal
Mm-hmm.
failure, urinary tract obstruction, indwelling catheter, urinary
Mm-hmm.
procedure like cystoscopy, or when
Mm-hmm.
there's immunosuppression, or when it's hospital acquired. Okay, for these conditions considered complicated. Okay, and how about if the patient is pregnant, complicated cystitis is pregnant, what do you give?
So you don't give Bactrim, okay? And you don't do fluoroquinolones. You can do cephalosporin. You can also do amoxicillin.
You can do amoxiclav, you can do
Yeah.
cephalexin,
Which is cephalosporin, right?
Yeah, or you can do sulfadoxime, that's another one, or you can do fosfomycin.
Okay.
So how is the management of outpatient versus inpatient pyelonephritis? What is the difference?
So outpatients, you can do oral medication. So you can do it if they are able to tolerate oral medication, and if they don't have nausea, vomiting, I guess, yeah, you can do hospitalized, and they do IV. One, if the patient is unreliable, then if they have nausea, vomiting,
Yeah,
I
but
guess if they have
what
sepsis too, I don't know.
antibiotics? What
Oh,
antibiotics?
what antibiotics? Okay. Yeah. Oh, what is it again that you can give? You can do outpatient. I guess you can do oral fluoroquinolones, bed for hospitalized one. Oh my, you can do. I think you can do ampangent or something like that. Yeah, that's all I know. What do you
Yeah,
give?
so for the outpatient, you give them Cipro or
Mm-hmm.
levofloxacin, fluoroquinolone.
Yeah.
And
So fluoroquinolones. Okay.
inpatient, you give them IV antibiotic,
Mm-hmm.
either Cipro or you can give them aminoglycoside plus ampicillin.
Okay. Ampangent. Yeah.
Yeah, that's it.
All right.
Okay. So now this is an interesting case, and I think it's a little bit of it's a good case. So if you are a 45-year-old male who presented with altered mental status, when I check your labs, I found the bicarbonate to be 13, and the
Okay.
urinalysis shows rectangular envelope-shaped crystal.
Mm-hmm.
So what poisoning is that?
Ethylene glycol
Good job.
poisoning.
Good job. Good job. Yeah, so you smart. So you figured it out from just the acidosis and renal failure can
Mm-hmm.
cause
Yes.
renal
Mm-hmm.
damage. Creatinine. So I could have made it easier by giving you more, like they have increased osmolarity in the plasma 350,
Right.
creatinine 2.5, BUN 28, and the ABG 7.20. But you're smart. You figured it out by just giving you two clues, which is good. That's gonna save you a lot of time in the exam, so that you don't need to read everything. Okay. So now, if you are a 32-year-old male who with a known history of recreational drug abuse,
No history.
no, he has a history of drug abuse.
Okay.
Okay,
Mm-hmm.
he was found in the apartment with a pool of urine around him. He's confused, not oriented. Okay, now when you check his labs, you found the CPK is 26,000,
Mm-hmm.
potassium is 5,
What? What is 5?
potassium.
Okay, potassium is 5. Okay.
Urine tox is positive for cocaine and cannabinoid.
Mm-hmm.
What this patient is at greatest risk for?
At risk for.
Mm.
So that will be renal failure. He has a rhabdomyolysis.
Yeah, it's acute renal failure,
Mm-hmm.
rhabdomyolysis. Yeah. So you know how to treat rhabdo, right?
A lot of IV hydration, hydrates.
Yeah,
And
yeah,
then, yeah.
yeah. And sometimes there's a lot of hydration. They can give mannitol too.
Mm.
Yeah. Okay. So how do you differentiate prostate cancer from BPH?
Okay.
Mm?
So prostate cancer is gonna be, I think, is it lateral, just on the sides?
Yeah, yeah.
That's why it doesn't really cause a lot
Yeah,
of
that's
symptoms.
the most thing. Like
Yeah,
it's
BPH is
lateral.
central. Mm-hmm.
Yeah, the lateral lobe and the BPH center. So on exams, we have asymmetric enlarged nodules and firm prostate,
Oh, okay.
and
Mm-hmm.
BPH symmetric enlarged and smooth. Okay.
Sure.
Now, if you are a 28-year-old woman who was treated for sunburn with
Sorry, can you repeat that again? BPH is symmetrical, enlarged, and smooth.
yeah, symmetric.
Okay.
And the
Cancer
cancer,
is asymmetry,
large
nodular.
firm prostate, yes. Okay, so now if you are a 28-year-old woman who was treated for sunburn on the face and arm 6 months ago, okay,
Okay.
and you had a sunburn on the face, and 6 months ago you had a sinus infection, okay, on examination there is bilateral pitting ankle edema, and there's normal heart and vesicular breath sounds. So when I order labs, so you see it's interesting. You see sinus infection, sunburn, okay? This you connect these two, and then I'll give you the labs. The labs, the now this is gonna give it away. I think you're gonna know. The C3 is 30.
Okay.
Do you need other informations, or
I'm thinking
what do you think? I can give you the creatinine 2.5, and there is RBC cast.
sunburn. I'm thinking either it's gonna be lupus or it's gonna be what do you call it? Or it's gonna be wedgeness. I don't know. Between those two, am I going the wrong way?
No, no, you're going the right way. Good job. Yeah, yeah, it's lupus. Lupus.
Okay.
Yeah, it can be, so it can be Wegener, but Wegener usually doesn't cause like a sunburn like this.
Yeah, that's what I
That's
thought.
the difference, yeah. So this is, they give you like one difference, and you should be able to know from that.
Mm-hmm.
The creatinine is high, there's thrombocytopenia, okay,
Mm-hmm.
also cast erythrocyte and everything. Yeah,
Sometimes they can give you the antibodies too, right? Mm,
yeah,
they
yeah.
want to be nice.
Yeah, yeah, but no, they didn't give you the antibiotics. Yeah, sometimes they're nice enough to give you that. Okay, now if you are a 71-year-old male with inclusion body myositis, you brought to the emergency room with a blood pressure of a 90/60 and the sodium is 164. On physical exam, there is a frail man with dry oral mucosa and decreased
There's
axillary
what? Physical exam, what? Sorry.
friable dry oral mucosa and decreased axillary perspiration. So what should you do right now? Blood pressure is 90/60. So this
Oh, so
patient,
the person is dehydrated.
yeah, I just give him
So
IV fluid.
hypernatremia.
Yeah,
Yeah, so fluid.
this is a condition called hypovolemic
Hmm.
hypernatremia. You
So
treat,
this will be regular isotonic saline
yeah, yeah, just
infusion.
zero point
Yeah.
0.9 normal saline.
Hmm.
Okay, so this one is a simple one. You have hypertension with flank mass. What is that?
Oh, what do you call APKD,
Yeah, yeah,
autosomal
yeah, yeah.
polycystic.
PKD, yeah. These are
Yeah.
simple questions. I shouldn't ask them. So if you are a 43-year-old woman with hepatitis C and you presented with epigastric tenderness, when I ordered the ABG, I found it 7.4. Okay, your blood pressure is 100/70 while supine. So what should I do right now? And the potassium is a 3. So what do you think? What should I do right now?
Potassium is 3.
Yeah, and the pH is 7.49.
So that's oh, metabolic alkalosis. Are they like vomiting? Yeah.
Smart, smart, smart. Wow, look at you. So you don't need history. Sometimes you just look at the labs and stuff. Yeah, I tried to make it. Yeah, I,
You're trying to trick me, right?
yeah. I'm trying to trick you, but you're
Your goal
always.
is to make me not answer, get the question right.
Yeah, yeah. I'm trying. Yeah, I like doing that, but you're always able to figure it out. So good job. Yeah. So I tried to hide the vomiting for you and answering, but you're right. Good job. So you knew it from the just the lab's value. So just give him IV normal saline and potassium. That's a metabolic alkalosis.
Mhm.
Yeah. So if you are a 34-year-old woman with headache and palpitation. Your blood pressure is 170. Okay, the urinalysis shows
Blood
12
pressure is what?
170 over 100 in both arms.
Okay. Okay.
Okay, and you have bilateral flank masses. So what is the complication of this condition?
So bilateral frank headache, palpitation.
Yeah, hypertension, bilateral flank masses. Yeah.
So if it's a female, are we thinking about fibro muscular? What do you call it?
No, you just answered it right. The flank mass with hypertension.
Oh, APKD.
Yeah. So now they're asking about the complication. They can have intracranial bleed.
Oh, complications. Oh,
Mm.
so a lot of things can be complications. It can be what do you call it? Aneurysm, right? They can have aneurysm. They can have what do you call it? Hepatic. Is it a cyst? So
Yeah,
cyst in
hepatitis.
the
Yeah,
liver.
that's the most
They
common one.
okay.
Yeah.
They can also have a diverticular, right?
Yeah.
They can also have a, I think this is the one they can also have. So aneurysm, hepatic cyst, diverticular.
They can also
Is it
have
also hernia?
hernia, abdominal wall, and
Yeah,
inguinal hernia.
ventral and inguinal
Yeah.
hernia. Yeah.
And they can have valvular heart disease like mitral valve prolapse and aortic
Yes, yeah,
regurg.
and aortic regurgitation. Yeah,
Yeah.
yeah,
So
MPV.
it
Yeah.
is interesting condition, yeah, like this. You know, like I remember ankylosing spondylitis also they had extra like systemic manifestation was interesting too.
It's so sad what people go through.
Yeah, it's very sad. And you know, medicine doesn't do much for them. Like it's just prolonging their life.
I know, it's
Yeah,
crazy. It's like, what do you do with these people?
yeah, like it's hard. Like
Yeah.
what are you gonna do for multiple? Like if you have a multiple sclerosis, like just cell trying to damage your nervous system. Like what are you gonna do for that? Like
Yeah,
yeah,
best treat them symptomatically here.
yeah, that's they're not gonna do anything. Yeah, that's
So we have a long way to go, right? In terms of
yeah, that's
medicine,
true. Yeah,
research, and things. Dr. Ali, did you do research?
yeah, I did, but a little bit, just a
Okay.
case report. How about you?
Yeah, I have like three three papers published and one still on the way. I don't know.
Wow,
Some people are having like 40 and 10 and
wow,
15, and I don't know.
yeah, that's cool. Yeah, I know some people like they have that. Yeah.
I don't know how they do it.
Yeah, no, I think they know someone and they know a researcher, and the researcher just attach their name even without doing any work. Some of them like this. Like you
Mm,
don't. Yeah, it's yeah,
that's interesting.
yeah. So if you are a 62-year-old male who presented with a severe back pain that began suddenly after you attempted to lift a heavy box,
Mm-hmm.
your pain radiated down the right thigh and leg, and coughing and moving make the pain unbearable. When
Mm.
rectal exam shows enlarged, smooth, non-tender prostate,
Rectal exam showed what?
enlarged, smooth, non-tender prostate. But
Oh, okay.
that's the problem now. You have a severe pain
Mm-hmm.
plus urine, like you're not able to urinate.
Mm.
So what's causing this urinary retention?
Is it not from um will I say like a cord compression?
Hmm?
Spinal cord compression
No, so it's like this. So you couldn't
or
urinate.
Quina
So
syndrome?
yesterday you had like you lifted a heavy box, you injured your
Mm-hmm.
neuron, and you had a severe pain yesterday. And
Mm-hmm.
since you had the pain till now, you're not able to urinate. So what do we call this condition?
I don't even know where you're trying to go, but tell me.
So yeah, so this is called the severe pain. When you have severe pain with a
Uh-huh.
mild urinary obstruction,
Uh-huh.
that can cause like for example BPH, that can cause urine retention due to inability to Valsalva.
Oh,
Yeah, this is like an interesting case. Like severe pain can cause urine retention if you have BPH.
really?
Yeah, yeah.
Okay.
So now this simple case, 42-year-old
So one
woman.
question now. So how do you differentiate this from something like, like Aquinas syndrome or medullary, what do you call it? You know what I'm talking about? The ones that come with some neurological problems too, unable to
Yeah,
pee and.
that's a good question. The way you differentiate it, physical exam. The Cauda equina syndrome, they have lower extremity weakness. That's what
Okay.
make it more likely. And even conus medullaris. Conus
Mm-hmm.
medullaris, they will have hyperreflexia because it's an upper motor neuron lesion. And
Sure.
Cauda equina syndrome is lower motor neuron lesion, so
Mm-hmm.
it will cause hyporeflexia. And the Cauda equina syndrome, it's asymmetric, while conus medullaris is symmetric.
Mm-hmm.
And the conus medullaris, they have early urinary problem, while Cauda equina
Mm-hmm.
late urinary problem.
Mm-hmm. So what you're saying is it's gonna be more than urinary problem.
Yeah, yeah. While this
Okay.
guy has no lower extremity weakness.
Just urinary issues. Okay.
Yeah.
Okay.
Now, simple case. If you are a
Hmm.
42-year-old woman who began to feel increasingly fatigued and weak for the past 2 weeks, and you had anorexia, nausea, abdominal pain, your blood pressure 86/50, plus this is gonna give it away, plus hyperpigmentation of the skin. So what lab abnormality? What is the potassium level in this patient? What do you expect?
Potassium level. So this patient will have hyperkalemia.
Yeah, excellent hyperkalemia. This is adrenal
Elevated, yeah, adrenal.
insufficiency.
Yes.
So, if someone with a pre-renal azotemia, what do you expect will happen to the renal arteriole?
Or prerenal azotemia.
Mm.
You say what is gonna happen to what?
Renal arteriole is gonna constrict or dilate.
Oh, do they ask that on step 2? I'm kidding.
Yeah, yeah, they ask. Yeah, they do. As a matter of fact,
I
they
hate
ask
it.
that even in step 3.
I hate those questions.
Yeah,
So
because this
is
involves
it the efferent or the efferent
because
arterial?
this renin angiotensin aldosterone system, that's a very
Mm-hmm.
important concept. They're definitely gonna ask about it.
Mm-hmm.
So this is gonna
Are
go.
you?
You know, when you have prerenal azotemia, this is gonna increase the angiotensin too, so it causes vasoconstriction.
Yes, but what are you asking? Are you asking specifically for the efferent, or if, of course, both of them will be, but more especially the efferent,
Yeah,
right?
more the efferent. Yeah, the efferent will constrict, and the afferent will dilate, so that will enhance the perfusion for the kidneys. Yeah, so this is the efferent. Okay, will constrict. Okay, now another case. If you are a 50-year-old male who has a 2-day history of constipation and the upright X-ray shows gas distributed throughout the small and large bowel and some fluid level, urine sediment shows white BC, 2
Urine sediment was what?
urine sediment shows white blood cells, 2 per high power field, and red
Two
blood cells,
what? Oh, two per hyperfit. Okay.
yeah, red blood cells 15, and needle
15.
shaped
Okay.
crystals. Okay.
Okay. Needle shape. Uric acid. Okay.
Yeah, so what do you best next step for this patient?
Okay. Let's say so patient has constipation. Okay. Uric acid crystals
Mm,
and the red blood cell 15.
yeah.
So,
I'm gonna make it easier. This patient having intermittent right lower quadrant pain. So what do
oh,
you do?
stone. Yeah.
Yes, what do you do?
So what do you do? Oh, okay. So depending on, oh, okay, you're gonna do what do you call it? Renal ultrasound to check the stone. Oh, oh, CT. Do CT.
Excellent,
CT.
good job. Yeah,
Non-contrast.
yeah,
Non-contrast.
yeah. You do CT scan.
Non-contrast, yeah.
CT scan. Okay. Because it's a radiolucent stone. So
Right, yeah.
now, if you are a 57 homeless male who has an HIV, you presented with shortness of breath and non-productive cough, with a temperature of 102, and lung examination shows diffuse rales bilaterally. Chest X-ray shows bilateral patchy opacities in the lower lungs. Okay, and you've been treated for azithromycin, ceftriaxone, TMP-SMX, prednisone, and albuterol. On the third day of hospitalization, you developed potassium of 5.9 and creatinine of 1.5. So what's causing these labs abnormalities?
It's and creatinine of how much?
1.5?
Okay, so basically the patient has pneumonia and then treated with azithromycin, ceftriaxone, Bactrim, and what else?
That's it. The other ones are not important. One of them
Okay.
causing the problem. So which one?
Yeah, Bactrim. Yeah.
Excellent. Yeah, trimethoprim. So what are the medications that can cause hyperkalemia?
Oh my, I hate that question. So I know, okay, Bactrim can cause that, lisinopril can cause that, spironolactone, I think also cyclosporin. What else? Those are the ones that I know.
Ibuprofen, like non-steroidal anti-inflammatory drugs,
Yeah,
can cause that. Yeah.
NSAIDs, yeah.
Digoxin,
Okay.
another one.
Oh, yeah. Okay.
ACE inhibitor, ERB, K-sparing, and non-selective beta-adrenergic blockers can cause that too.
Okay.
Heparin can cause that. Why?
Okay.
Why cyclosporin and heparin cause that hyperkalemia?
Why do they cause that?
Because they block the aldosterone. So the heparin block aldosterone production, and the cyclosporin blocks aldosterone activity.
Mm,
Okay, so the
okay.
aldosterone is the potassium thrashing hormone,
Mm-hmm.
and the other one is succinylcholine.
Succinylcholine. Okay. Okay. Yeah. Yeah. That's true.
So
Mm-hmm.
this causes
How does that one work too?
extracellular leakage of potassium through acetylcholine receptors.
Okay.
Okay, okay, if you are a 38-year-old woman who presented with a right flank pain radiating to the groin plus hematuria, when I do ultrasound, I found 8 mm calculus in the distal right ureter. So what should I give you right now?
8 millimeter stone
Yeah,
in the right urethra.
yeah.
Okay. So if the stone is still there, if the kidney stone is still there, you do the IV fluid, then you do pain medication, and you do I think Flomax, tamsulosin.
Tamsulosin,
Uh,
yeah, good job, yeah. I've lowered, yeah, good job. Good job. Now, if you are a 60-year-old male who presented with dizziness, fatigue, and weight loss, when I check your potassium is
oh,
5.9.
hold on, Dr. Ali. Before that, so you're giving all these things, for the stone to pass. When do you decide to go do like surgery? I think is it from 10 millimeter?
Yeah,
Once,
for more
yeah,
10
1
mm.
centimeter, right?
Yeah, for more than 10.
Okay.
Yeah, you're right.
All right, sure. Okay.
Yeah. Now, if you are a 60-year-old guy presented with fatigue, weight loss, with hyperkalemia, hypoglycemia, and eosinophilia.
Hyperkalemia,
Yeah, hypoglycemia and eosinophilia.
hypo or
Hy-
hyperglycemia?
hypoglycemia. So,
Hypo,
yeah,
okay.
yeah. So, what acid-base status that expected here?
Metabolic acidosis.
Yeah, normal anion gap metabolic acidosis. Because this is
Yeah.
one is a primary adrenal insufficiency.
Mm-hmm.
So how about if I tell you this guy have a right upper lobe cavitary lesion? So what's causing his adrenal insufficiency?
Right upper lobe, what?
Cavitary lesion.
Or right upper lobe, which will be TB.
TB,
Okay.
it can be caused, yeah, this adrenal insufficiency can be caused, autoimmune is the number one, and it can be caused by TB, HIV, disseminated fungi. It can be caused by meningococci. What do we call that?
Which oh the water something Friedrich
Yeah,
House
yeah,
something something.
it's the Waterhouse-Friderichsen syndrome, anticoagulant cause, and metastatic cancer, lung.
Mm-hmm.
Yeah, I remember like I was watching these sketchy micro. It was funny. I remember they were drawing a picture of a water house and got exploded and meningococcal. Yeah, that's funny.
Really?
Yeah, they make it like a cartoon, like these micro.
Mm-hmm. Mm-hmm.
Yeah,
And you see, you still remember that.
yeah. So it was like,
That's good. Mm-hmm.
yeah, it was funny. Like, yeah, and then the fever, they make a fever beeper and stuff.
Hmm.
Okay, so how does acute adrenal insufficiency presentation different from chronic?
Oh, okay. So primary adrenal. In primary adrenal, so the problem is going to be in the adrenal gland.
No, I said acute versus chronic. The
Okay.
presentation, like symptom wise. So you know
Um,
the acute,
oh, the only thing that I know
the
is the hyperpigmentation something. I don't know if there's any other one. I don't know. Okay, tell me.
yeah, good job. This hyperpigmentation is big one,
Mm-hmm.
and with the acute, you may have shock,
Oh,
tenderness with,
shock.
yeah, tenderness and deep palpation of the abdomen, unexplained fever, and then they have all of these good stuff: nausea, vomiting, weight loss, and hyponatremia, hyperkalemia, hypercalcemia, eosinophilia. But
Mm-hmm.
with the chronic, you have hyperpigmentation or vitiligo. They can have that too.
Mm-hmm.
And then they have weight loss, nausea, vomiting, weakness, and all of these lab abnormalities. So how
Okay.
do you diagnose it?
ACTH.
Yeah, so you measure ACTH.
Yeah,
It's
what is it called again?
yeah
Is it metirapone or
yeah.
something like that?
So yeah, you do ACTH stimulation test,
Mm-hmm. Mm-hmm.
and then you measure ACTH and the cortisol.
Mm-hmm.
So for if you have low cortisol, high ACTH, what is
Okay,
that?
hold on. Low cortisol, high ACTH, primary.
What if both low?
Um, okay, hold on. I like to process this in my brain.
Hmm.
So primary, the problem is in the adrenal gland. So adrenal gland makes cortisol. Cortisol will be low, and then the pituitary gland is gonna try to. Okay, so primary will be decreased cortisol and increase ACTH.
Yeah, and the
And
secondary
then
both low.
secondary, yeah, both low because the problem is now in the pituitary. So low ACTH. If you don't have ACTH, you can make cortisol. Yeah. So low.
Okay,
Yeah.
so if you are a 50-year-old male on a dialysis, so what is the most common cause of death for you?
Cardio,
Yeah,
vascular.
cardiovascular. 50% of them they die from cardiovascular causes. So now, if you are a 40-year-old woman,
Hold on. I need
yeah,
a 1 second. I need a paper. I like to write some things down. My paper. I run out of paper.
okay,
Sorry.
no, it's okay.
Okay.
It's
All
good
right. Go
that you're
ahead.
writing. This is gonna really consolidate that in your brain.
Yeah. I like to write.
Yeah, it's gonna get you like the 270. Yeah, yeah.
270, Dr. Ali. Come on.
Yeah, you can get it. It's not that hard. Yeah, okay. So if you are a 40-year-old woman, okay, who has intense thirst and craving for ice water, your sodium is 156. Serum osmolarity is 328. Urine osmolarity is 180. So how can I treat your condition here?
Okay, so this patient has hypernatremia. Hypernatremia, of course, you're going to start with fluid. So urine osmolality is 180, right? What else?
Yeah, you give them fluid. You're
Yeah,
right. Yeah.
yeah.
So this, when you have patient with a hypernatremia, you assess volume status. If
Mm-hmm,
it's a euvolemic, just free water supplementation.
mm-hmm,
But if they are hypovolemic, you look at the symptoms. If they are symptomatic hyponatremia,
mm-hmm,
which are present with confusion, lethargy, then you give them 0.9 saline until euvolemic, and then you convert to 5% dextrose. But if you're not symptomatic, you just start with 5% dextrose.
mm-hmm.
Okay. You know, these
Okay.
things with medicine, like it's crazy. Like you can forget them easily if you don't keep
Of
reviewing.
course. Yeah, and sometimes that's not even what they do in the free world. Like when you go to your clinicals,
Yeah, they don't do that.
they don't do
And
they
you
don't
know
do all
the
this.
materials, like you forget them like this, like these things. Like I spent so much time and like memorize the hell out of them. And but
Mm-hmm.
now if I don't review them, it looks
You
like
don't remember.
yeah, it looks like something new. It's true. Like when I review it, I remember
Uh-huh.
most of the stuff. But still, if I don't review, like it feels
Yeah,
like
I
I
know
don't.
what you mean.
Yeah, like still
Even
I
when
don't
you're
remember.
reviewing it, you have to do like a repetition over and over and over again
Yeah,
to
yeah.
get
So
it in
you
your
gotta,
head.
yeah. So you gotta extend your UWord subscription for residency too.
Really? You think
Yeah,
so?
yeah. This I know my friend. Like he bought a UWord for when he started his residency. He bought UWord for Step 2 CK.
For which you were step 3 or step 2?
Step 2, he was Step 2.
Step 2?
Yeah, he's doing it in residency.
Really?
Yeah, yeah.
Oh, wow. Interesting.
Yeah, because
That's a lot of money.
he's gonna need that. Yeah, but you're gonna be a resident, so money's not gonna be an issue for you. It's gonna be educational material and stuff.
Yeah,
You're not
but they
that.
have like books that you can use for
Yeah,
your residency. There's
yeah,
one which is very, very good. It's just like doing your world. It's called Washington Manual.
really, yeah. And there's,
Uh,
yeah, there is also KSAP. You can do that too. Okay,
and
yeah.
then they have this pocket medicine book.
Mm, yeah,
Those
yeah,
two books, can get you anywhere.
yeah. That's true. Yeah. Okay, so now rapid correction of hyponatremia. What can cause that? What can cause?
Rapid correction of hypo,
Yeah,
low sodium.
yeah.
Yeah, the central myelopontine something
Yeah,
something.
osmotic demyelination syndrome. Okay.
Hmm.
So now, if you're a 70-year-old woman with a sodium level of 147, potassium 5.2, creatinine is 1.8. So what can I do to treat your condition? And your blood pressure is 92 over 50. So this, you remember this hypernatremia with hypovolemia. So how do you treat that?
Hyponatremia
Hypernatremia with
or
hypovolemia.
hypernatremia with hypovolemia.
Yeah.
Mm, okay. Hypernatremia with hypovolemia. I think you just said it. You said it too fast.
Yeah, IV. Just give them IV fluid, crystal.
Hmm.
Yeah, you remember we just talked. This is a repetition.
Yeah.
Same thing. Yeah. So if you have diabetes with a 2+ protein on your analysis.
Diabetes, okay.
Yeah.
Two
So this.
plus.
Yeah. So what's causing that? They said what you asking? What's causing that? So what's the answer was the basement membrane changes. We
Uh-huh.
talked about like this basement membrane changes because hyperfiltration. So that's why you
Uh-huh.
tend to lose protein. Okay?
Okay.
Another question, you don't need to screen for bladder cancer. There's no screening for bladder cancer.
Mm-hmm.
Okay, now this is a good one. So if you're a 65-year-old diabetic male who presented with pneumonia, like fever, cough, low parental filtrate,
Mm-hmm.
but you have a creatinine of 2, so what's most appropriate next step right now? And you're taking aspirin, statin, metformin, sitagliptin.
Aspirin, metformin, what?
Statin and sitagliptin.
Mm-hmm.
Taking low dose aspirin. So what antibiotic should you discontinue right now?
You didn't tell me what antibiotics he's
I
taking.
mean, sorry, what medication do you discontinue now?
Metformin.
Yeah, metformin because he's having renal failure out of it.
Yeah.
Now, good question, good stuff. If you are a 55-year-old woman who presented with an 8-year history of chronic low back pain,
Eight
and
years.
yeah, and you've been taking naproxen forever. So when I did urinalysis, I found 2 plus protein. White BC is 10 to 15 per high power field, and sediment showing white BC cast.
Mm-hmm.
2 years ago,
Acute interstitial nephritis.
yeah, it is a tubulo interstitial nephritis. Good job. Because this chronic analgesic
AIN.
can cause UTI, tubular
Mm-hmm.
interstitial nephritis, and papillary necrosis. Can cause all of these three things.
Mm-hmm.
And the other effect can cause premature aging, and can cause,
Premature aging.
yeah, it can cause atherosclerotic vascular disease too.
Mm.
Okay. You know, it's funny. My mom yesterday she was saying like she was telling the other like I have my nephew. He sits on the iPad a lot, so
Mm-hmm.
but he shakes his head. So she told him like because you play on iPad a lot, so you shake your head. That's why. That's one of the reasons why you shake your head. Electricity goes to you, so don't play on an iPad. So that's another.
But that's true.
Huh? Really?
I
No,
think so,
how?
yeah.
No, how?
I don't know. I think too much light going to their eyes and brain and whatever. I have seen that,
Really?
He's shaking his head too much.
Yeah,
Yeah, tell him just remove that iPad or whatever from him and see
yeah,
what happens.
yeah. No, she was. Yeah, she just wanted to scare him, just to not to use the iPad. Yeah. Okay, so if you are a 24-year-old male who presented with a 1-day history of mild back pain, when I ordered urinalysis, there's a 3 plus of protein and 50/75 red blood cells per high power field, white PC 3 per
Huh?
high power field. So what's causing your problem here?
3 plus protein, 50 to 75 red blood cells.
Yeah, and 3 plus proteinuria.
Did you? Yeah, you said 3 plus proteinuria, and then red blood cells, right?
Yeah.
Back pain. So this sounds more like nephritic um, nephritic range.
Yeah, it is glomerular hematuria.
Mm-hmm,
It's a good job. So the most common causes for that are either Alport syndrome,
mm-hmm,
glomerulonephritis. They
mm-hmm,
present with nephritic syndrome, which is hypertension,
mm-hmm,
oliguria, and elevated creatinine.
mm-hmm,
And the urinalysis, they have a blood and protein, RBC
mm-hmm,
cast, and
mm-hmm.
dysmorphic red blood cells.
Yes.
That's very
Okay.
important. While non-glomerular hematuria, they present with a normal appearing RBC. Okay, they have a blood but no protein, and they have dysuria frequency. They have flank pain also because it's caused
Mm-hmm,
by renal stone, papillary necrosis, infection, cancer, nephrolithiasis. But this is the non-glomerular hematuria. Okay. Okay.
okay. Sure.
Now, if you are a 36-year-old male with a Hodgkin lymphoma and 4 plus proteinuria, so what's causing your issue here?
Hodgkin membranous.
No, it's minimal change disease because when you have
Oh, 36-year-old what?
even
Male?
even in a 36-year-old, you can have minimal change disease.
Mm.
So if you have a glomerulonephritis and you have either an African American or Hispanic or
So hold
obesity,
on, hold on, hold on.
HIV,
So
heroin,
the Dr. Ali, hold on.
yeah,
So the Hodgkin's plus nephrotic range you said is minimal, right?
yeah, minimal because the cytokine causes that.
Okay.
Because minimal change is associated with non-steroidal and lymphoma can increase risk for minimal change. And upper respiratory tract infection increases risk for IgA. But how about African American, Hispanic, obesity, HIV, and heroin abuse? Increased risk of what type of
Focal
glomerulonephritis?
focal
Focal
segmental.
segmental glomerulonephritis. How about if you have adenocarcinoma of the breast, lung, and you're using non-steroidal anti-inflammatory drug, or hepatitis B or SLE? Increased risk of what type of glomerulonephritis?
Membranoproliferative.
So hepatitis B and C and lipodystrophy increase risk for membranous or proliferative glomerulonephritis, but adenocarcinoma of the breast or lung or non-steroidal or SLE can increase risk for membranous glomerulonephritis, okay?
Okay.
Not membranous proliferative, yeah. So those, they like to ask about these things too.
So membranous will be all those cancers that you mentioned.
Yeah. So if you,
And membranoproliferative will be the Hep C, Hep B. Okay, the other ones. Okay, all right.
so what are the side effects of chlorothalidone?
Okay, so chlorothalidone is like so hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia. Yeah.
Yeah, it causes hyperglycemia and calcemia, and hyponatremia, kalemia, and magnesemia.
Right.
So now this is a good one actually, and it's a tough one to ask or
All
try.
right. Let's see.
So you remember we had a question like this: if you have radio-opaque stone and your urinary calcium excretion of 350, then the best way to prevent stone, if you give them thiazide, you know that, right? We talked about it. Now, so what are this is the drug therapy that prevent nephrolithiasis. Like you have thiazide, okay? What else? What other drugs that inhibit recurrent stone?
You can also, I think, what do you call it? Those sodium something something. What do you call it?
Potassium. So potassium citrate.
I mean, triamterene, right?
No. So
And the other one.
allopurinol prevent
Okay.
hyperuricosuria related to stones,
Right.
and
Okay.
urine alkalinization like potassium citrate and bicarbonate salt, okay? And
Bicarbonate salts.
yeah,
Okay.
those and thiazide, those inhibit renal stone. Those are the drugs. Now, what are the dietary changes that you do to decrease recurrent stone formation? That's a
Okay.
little bit.
Decrease oxalate diet.
Yeah, what else?
Decrease. I think decrease low oxalate, low protein,
Yeah, what else?
and a lot of fluid. And then I think also you don't do, let me see, so low protein, low oxalate, IV fluid. Is it like green leafy vegetables?
Yeah, you decrease sodium, oxalate, and protein, and increases fluid, citrate, and calcium,
Okay.
or normal calcium too. Normal calcium
No,
intake.
come on, yeah, they say calcium, you don't have to change your calcium
Yeah,
diet.
that's the interesting part. So
Yeah.
if so actually if you decrease risk, if you decrease calcium, okay, this is not good for the calcium stone. If you take moderate amount of calcium, this is gonna help you to decrease calcium stone formation. Okay, now what are the causes of normal anion gap metabolic acidosis?
Or normal anion. So normal anion will be, is it hard? Something? Okay, let's start. Let me see the ones. Oh my goodness, my brain is blank right now. Okay, I know about renal tubular acidosis. Also hyperadron diarrhea, hyperadrenalism. It's hard something, that mnemonic. out here. From step one, I'm trying to use my
Yeah.
step one
Yeah, you can.
knowledge.
So those are the things: renal tubular acidosis, urethral
Mm-hmm.
diversion, ileal loop. It could be iatrogenic. It could be carbonic anhydrase inhibitor, citozolamide. It could be
Mm-hmm.
fistula, pancreatic, or ileocutaneous fistula. It could be
Mm-hmm.
diarrhea. All of those can cause normal anion gap metabolic acidosis.
Mm-hmm. Also, like spironolactone, saline, all those things, hard ass, whatever.
Yeah,
That's
because these things, that's the trick behind it. These things, they adding acid to the blood without, it's from the blood. It's not extra.
okay.
So it's not like I'm adding ethylene glycol or something, alcohol. So for renal tubular acidosis, they're just not unable to excrete acid. That's why they have acidosis. Diarrhea is the same, like the same thing. Like you're not adding stuff. Fistula, same, can predispose to diarrhea. Urethral
Okay.
diversion also same. Okay, so those are the things. Okay,
Okay.
now, so how do you manage patient with a calcium of 15 versus patient with a calcium of 13 versus, do you mind if I pick this call
Yeah, go
really
ahead.
quick?
Mm-hmm.
Just a second. Okay, let's finish the first part. We've got a few questions left. Okay, so now, yeah, so how do you manage calcium hypercalcemia for a 15 versus 13 versus 11?
Okay. So the severe, if it's greater than 14, you have to immediately give them like a IV fluid like saline, and then give them calcitonin, and then eventually put them on bisphosphonate. Then if it's, you said, what did you say, 11, 13?
Yeah, 13 and 11. Good job, yeah, good job.
Okay.
Yeah, so IV fluid,
Yeah. Mm-hmm.
calcitonin, and you avoid loop diuretic unless the patient has heart failure. Okay.
Mm-hmm.
And you put them on zoledronic acid long term. Okay, so now moderate, how do you treat that?
So for moderate, just put them on that bisphosphonate.
Yeah, so moderate,
Yeah.
no immediate
Mm-hmm.
therapy required unless symptomatic. Okay, and the treatment is similar, you just give them
Mm.
bisphosphonate. How about the mild? The 11, yeah.
Mild,
Less than 12, yeah.
um, hmm, just, I don't think, do you give them anything for those mild ones? I think you just like watch them or observe them and
Yeah, you should counsel them on avoiding
yeah.
thiazide,
Mm-hmm.
diuretic, lithium, volume depletion, and prolonged bed rest. Okay.
Avoid prolonged bed rest. Okay.
Yeah, because immobilization can
So
increase risk.
avoid all the things that can cause hypercalcemia.
Yeah.
Okay.
So now this is very good question actually. I love this question. So
All right.
when you are a 27-year-old male who
27.
had
Okay.
fever, joint pain that's been treated by cephalexin for skin
Cephaloxin.
infection, okay? So I gave you cephalexin, but then
Mm-hmm.
you presented with a dark urine, fever, skin rash. When I
Dark
ordered,
urine.
yeah, when I ordered urinalysis, I found 8 RBC per hyporphyl, 12 white blood cells, and white blood cell cast with eosinophil urea and mild degree of proteinuria. So what's next step here? What's
So
causing this issue?
stop the medication, the cephaloxin,
Excellent.
and
So this is
yeah,
called interstitial nephritis. What
itis. Mm-hmm.
what are the other medications that can cause interstitial nephritis?
Okay, so cephaloxin can cause it. NSAID can cause it. NSAIDs. What do you call it? Those are the two major ones that I know.
Yeah, you have
Um,
you have cephalosporin can cause that.
mm-hmm, mm-hmm.
Penicillin, sulf
Penicillin,
okay, sulfonamide,
sulfur. Mm-hmm. Okay.
okay, sulfonamide containing diuretics, non-steroidal anti-inflammatory drugs,
Mm-hmm.
rifampin, phenytoin, allopurinol.
Phenytoin, allopurinol.
So you can,
That's true.
I divide them into three categories. Number one, cephalosporin and penicillin. The second one, the S one, sulfonamide containing diuretic and non-steroidal. And the third one is rifampin, phenytoin, allopurinol.
Okay, let me see if I can get it. So you said the first one, penicillins and cephalosporin. Then the second one, sulfur NSAIDs. Then the third one, rifampin, allopurinol, and what else?
And phenytoin.
Phenytoin. Okay.
Yeah.
Okay.
The symptoms they present with fever, arthralgia, and skin rash.
Rifampin, allopurinol.
Okay. So this is how you spot it on the vignette. Fever,
And
arthralgia,
phenytoin.
skin rash, white BC cast. Okay.
Mm-hmm.
The treatment, just discontinue the medication and they will get better. So now this is a easy one. 17-year-old guy with hexagonal crystal on urinalysis.
17-year-old?
Yeah, hexagonal crystal on urinalysis. What's causing that?
Cola.
Yeah, amino acid transport
Cysteine.
abnormality. Yeah. Cysteine, lysine, arginine, ornithine. So the best thing to improve communication is having implemental sign-out checklist. That's an important one. These are ethics.
I love ethics.
Yeah.
Are you gonna go through ethics?
Yeah, just a few questions. I'm just seeing if there's anyone that's important. I can hospitalize, tell those, respect the patient. The patient don't want a treatment, just don't treat him. Don't discuss your patient information with someone. You do hospice if you focus on the quality of care, when you do symptom control, nausea, vomiting, dyspnea, interdisciplinary team, medical, nursing, psychological, will all be involved. And service is provided at home, and the prognosis is less than 6 months. Okay, that's when you do hospice. Those are just a few questions like I mixed with renal, so I'm just gonna go through if there's any tough one, and then we'll continue renal second part. Would you try? Yeah, I don't think I'm not seeing anyone that's worth discuss. Do we need to obtain permission? Do not take fresh drive. Don't take a fresh drive, as only small gift accepted. Okay, small gift that directly benefit patient are acceptable. If someone's angry, tell him why you're angry. Tell me about your bruises and details if you have some bruises. If someone wants after hour, just tell her schedule through regular hour. Yeah, that's okay. Let's back to second part of renal. Okay, got a few more questions. Okay, so if you are an 83-year-old woman who have a blood pressure of 96/50 and a heart rate of 112.
Blood pressure.
Yeah, so it's having some sort of shock. Okay.
Oh, hold on. I didn't get the blood pressure reading.
It's 90/50. Okay, and the tachycardia. Your sodium is 121. Potassium is 3.8. And white BC is 13,000. Okay, so they're asking what's the mechanism that explain this hyponatremia. So this patient have sepsis and hyponatremia. So what's causing this hyponatremia?
Infection.
Yeah, so there's just the causes of hyponatremia. So there are different types. There are hypovolemic hyponatremia. So what could cause hypovolemic hyponatremia?
Okay. So hypovolemic hyponatremia will be things like I remember this one. Let me see. Hypovolemic dehydration, vomiting, diarrhea. Also, medications like diuretics, ACE inhibitors, right?
Yeah.
So would this one be
Yeah, good job. Yeah,
dehydration?
so those things plus primary adrenal insufficiency and volume
Mm-hmm.
depletion, acute blood loss
Mm-hmm. Mm-hmm.
can cause you. How about euvolemic hyponatremia? What could cause that?
Or euvolumic. Okay, euvolumic will be like I remember he's SIADH, hypothyroidism, he's or has adrenal insufficiency, then psychogenic polydipsia, and drinking a lot of beer.
Yeah, so secondary adrenal insufficiency. So primary adrenal insufficiency causes hypovolemic hyponatremia, while secondary adrenal insufficiency causes euvolemic. Other stuff due to side dish, due to drugs, malignancy, could be psychogenic polydipsia, it could be hypothyroidism.
Mm-hmm.
Now, last question, what could cause hypervolemic hyponatremia?
Yeah, all those volume overload, CHF, cirrhosis, nephrotic syndrome, or kidney disease,
Good
volume
job.
overload. Yeah,
Good job, smart.
I hate those electrolytes. Ugh.
Uh-huh. So post-ictal bicarbonate of 17, what's best next step?
Post-ictal
Yeah.
seizure.
Yeah, so what do you do for that?
You said bicarbonate of what?
17 in the blood.
17 is metabolic acidosis, right?
Mm.
Post-ictal seizure.
So this
So how
patient,
do you treat them?
yeah, this one just observe and repeat labs after 2 hours.
Okay,
Okay, because
yeah,
this can
that's true.
happen.
Mm-hmm.
So if you have thin, smooth, regular wall, simple renal cyst, how do you treat
Thin,
that?
thin, smooth, regular wall.
Yeah, renal cyst, how do you treat that?
Oh, it's benign. Yeah, I guess nothing.
Just reassure. But if you
Mm-hmm.
have thick, irregular, multilocular, multiple septi, heterogeneous content, contrast
Complex is.
enhancement, if there's pain, hematuria, okay, require follow-up and urologic evaluation.
Mm-hmm.
How do you manage a cyclovir nephrotoxicity?
Oh, hydration, hydration, hydration.
Yeah, good job. Okay, so
I'm
now this is,
tired. Ooh.
what is it?
No, I said I'm tired.
Yeah, could you handle 30 minutes more?
Remember 3:45. I'm leaving.
3:45. Okay, so we can, let's,
Yeah.
15 minutes. We got. Okay, so let's try to squeeze it in. Okay, if you are a 68-year-old male who
Mm-hmm.
have an abdominal discomfort and difficulty in appreciating masses due to obesity, post-surgical. So post-surgical, you have you only avoided 200 ml of urine and creatinine 3.5 and 70. So this is post-operative urinary retention.
Mm-hmm.
That's the clue. But the trick is that in someone who's obese, it's hard to tell if there
Right.
was a urine retention. So how do you manage this patient?
Cut the patient.
Hmm?
Urine catheterization.
Yeah,
You,
exactly. Urine. So when you have history and physical for acute oliguria, best thing
mm-hmm.
you do, bedside bladder scan to assess for urine retention. That's the
Right.
first thing. If
But this
there's
patient is obese
yeah,
and you're not able to tell.
yeah.
Yeah. So,
If there is a significant urine retention, then you do urethral catheter to decompress the bladder.
Okay.
And then you order serum, urine, biochemistry plus imaging, and you treat underlying cause, like if there is a BPH, malignancy, theology
Mhm.
consultation.
Mhm.
But what if there is no significant urine retention? What do you do?
Do you give them IV fluid and go from there?
If
So
there
are
is,
you saying when you do the catheterization, there is no urine coming out? I
no, no,
don't
there is,
understand the
no,
question.
no, there is, if you do, so if you do bedside scan and there is no urine retention, then you just do urine and serum biochemistry and imaging,
Oh, okay, okay,
evaluate for
okay.
other causes.
Okay, okay, okay.
If it's
I'm
a
trying to
pre-renal,
understand your
if,
question.
yeah, yeah, if it's a pre-renal, just give them fluid. If it's a renal, just treat the cause, like if it's a nephritis or whatever.
Sure.
Okay. Now, if you are a 55-year-old man with present with abdominal distension and a protein of 4 plus, so what are the complications for this condition if you have 4 plus protein?
Okay, so the patient can have what do you call it? They can have like a thrombosis because they'll have a loss of antithrombin.
Excellent. Can increase risk for
Mm-hmm,
atherosclerosis and
mm-hmm,
hypercoagulability.
mm-hmm.
Now, this is a simple one. Like if you had a sore throat 3 weeks ago, skin infection or whatever, and now your analysis showing proteinuria RBC cast, low C3. What's your diagnosis?
PSGN.
Yeah, that's an easy one. Just make sure the IgA nephropathy it's happened 3 days after this one too.
Mm-hmm, mm-hmm.
What is Winter's formula?
Oh, okay.
This is a good one.
Yeah, is 1.5 times bicarb plus 8 plus or minus 2, right?
Smart. Wow. Yeah, you're gonna make a really good internist. You can
I
see that.
am.
Yeah, see that. Yeah. So now, if you are a 60-year-old man who have a 2 weeks of worsening fatigue, when I examine you, I found bibasilar crackles, potassium of 6, creatinine of 1.7. So how can I treat this hyperkalemia here?
Okay, potassium of 6.
Mm,
Potassium of 6 and serum creatinine of 1.7.
yeah.
Okay, so this patient of any no, what do you call it? EKG changes, right?
Yeah,
So
EKG normal.
bibasilar crackles. Okay. So go ahead and do the what do you call it? That is it insulin plus dextrose or Abitrol inhaler, all those ones.
So this is the management of hyperkalemia. Okay, so how do you remove hyperkalemia? You give him furosemide and
Okay.
saline infusion.
Because of the bibasilar crackles. Okay.
Yeah, so you give him diuretics.
Mm-hmm.
We can do caution exchangeazine, hemodialysis. Yeah,
Isolate.
and
Okay. Yeah.
this is just to remove the body, slow acting. And rapidly you can give him insulin, glucose, beta 2 adrenergic agonist, sodium bicarb.
Mm-hmm. Mm-hmm.
What if you have a cardiac problem? What do you give?
Calcium gluconate.
Yeah, good job, calcium. So what are the sequences of EKG changes in hyperkalemia?
Oh my. So I don't know the sequence, but I can tell you what I know. So you have the tall peaked waves,
Okay.
and then which can go into, they can now have like I think QRS, prolonged QRS or QT, and then they can go into those, is it sine wave, something like that.
So this one I like to explain it by signals. Let me show you guys.
Okay.
Do you guys see my screen?
So,
Do you see my video?
yes, we can
Yeah,
see your
it's
face.
it's like this. You see, it's like take the EKG. You take the T wave like this, peak T wave, and then you
Okay.
prolong it, prolonged PR interval, and
Mm-hmm.
disappearance of P wave. Okay, like this.
Okay.
Okay.
Oh, so prolonged PR interval, not QRS.
Yeah, PR and
And
QRS
then,
widening. Okay, that's it.
okay, so tall, wide, and then flat.
Yeah. Okay.
Flat what?
Yeah. So you just take it out, boom,
Uh-huh.
boom, boom, like this.
And then say what it is again, the letters.
So
Dr.
peak
Ali.
T wave,
Uh-huh.
prolonged PR and QRS, disappearance of P wave. That's how it is. Like that's the sequence.
So there is also prolonged QRS
Yeah.
or just PR.
Yeah. Both. Like
Okay, all
PR
right,
prolonging
okay.
and QRS widening. Okay.
Okay, all right. So tall, wide, and
Yeah. Yeah.
that's a good one.
Yeah. Let me know when you wanna go pick up your kid so that we can end it by then, and then tomorrow hopefully we start by 2:45 so that we get a
2:45 or 1:45.
yeah 1:45 in your time, yeah, because right now
Okay.
I'm in EST, yeah, so it's one.
Oh, okay.
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 Okay, now if you are an 30-year-old African American with hyperkalemia and proteinuria,
30
what's
year
causing
old.
that?
Okay. African American
Yeah, with
with what?
hyperkalemia and
Mm-hmm.
proteinuria. So what's causing that? And
And
you have
protein.
HIV too.
Hyperkalemia protein and HIV.
Hmm?
Hyperkalemia, proteinuria, and HIV. Are you talking about the one that we talked about before?
Yeah, this is focal segmental
Yeah.
glomerulopathy. Yeah.
Okay. Yeah.
So what can cause crystal-induced acute kidney injury? What medications?
Acyclovir can cause that.
What else?
Crystal, right?
Hmm?
Allopurinol, not allopurinol, the tumor lysis syndrome
What other medications?
medications. Okay. Crystals. Yeah. Acyclovir. What else? I don't remember.
So sulfonamide can cause that.
Sulfonamide.
Yeah, methotrexate,
Okay.
ethylene glycol,
Methotrexate.
and one
Et-
HIV medications. Which
oh
one?
yeah, Edlinger glycol.
Yeah, and what
Um,
HIV medication causes crystal?
is it Indinavir?
Yeah, protease inhibitor too. Protease inhibitor control.
Indians.
And
Indians with stone.
yeah, India. Okay, yeah, fine. Okay, so if you usually presentation asymptomatic but can have increased creatinine 1 to 7 days of starting medication. When you order urinalysis, you have hematuria, pyuria, crystals, increased risk with underlying volume depletion or chronic kidney disease. The best way to manage it is that stop the medication and give them IV fluid.
Okay. All right.
So how do you? So there. What causes saline responsive metabolic alkalosis versus saline resistance, and how do you treat it?
Selling metabolic.
Huh? So metabolic alkalosis, there are two types. There are one that responsive to IV fluid and one resistant.
Yeah, the
So
vomiting ones will be the responsive ones. NG, aspiration and vomiting,
which
right?
one resistant?
Resistant will be like all those endocrine stuff, like Cohen syndrome, Cushing syndrome. I think at least those two,
Yeah,
Cohen's and Cushing's. Yeah,
good job. The saline responsive, vomiting, NG suctioning, diuretic, laxative abuse, decreased oral fluid intake, volume depletion, and the
and
saline
those weird kidney Barterman and Gilterman and Bartter syndrome, something like that, right?
yeah, yeah, yeah.
Yeah,
Yeah, those,
resistant. Yeah.
those are. And the saline resistance is the primary hyperaldosteronism, Cushing syndrome, severe hypokalemia.
Okay.
Hypokalemia. How does a metabolic alkalosis present like with a volume depletion status, like easy fatigability, postural dizziness, and muscle cramps? And if they have a hypokalemia, they have muscle weakness, arrhythmia, because that. So how do you differentiate urine saline responsive from saline resistance? What labs?
Chloride.
Urine
Urine
chloride. So
chloride.
what's the cutoff?
For chloride,
Mm.
man,
So if the urine
I don't know.
chloride is 15, what is that? Is it responsive or resistant?
If the urine chloride is 15,
Yeah, so by just giving you the pH is 7.5 and the urine chloride is 15. Now you gotta tell me metabolic alkalosis, but is it responsive or resistant?
resistant.
No, it is responsive. If it's less than 20, it is responsive.
Oh, 20 is the cutoff. Okay.
Okay. So this, if it's less than 20, that means it's the kidney is functioning. The kidney is retaining chloride. So that means there's some sort of dehydration. So if you give them fluid, they're gonna get better. But if it's more than 20, that means the kidney is not reabsorbing chloride. So that means there's a problem here. It's not saline is not gonna help here.
Okay, say it one more time, please.
It's you look if you have metabolic alkalosis, you check you order urine chloride. If it's less than 20, then this is saline responsive. You give them IV fluid. If it's more than
Okay.
20, this is IV fluid resistant. Okay.
Okay. Okay. All right.
Okay. The treatment, you treat the underlying cause to reverse generation phase in all causes. Okay, and then this. How about the saline responsive? You give them normal saline to correct the maintenance phase. Okay. Now this is a tricky one. Okay, a lot of students confuse that. So when I do the water deprivation test, which basically I don't let you to drink any water 2 to 3 hours before I test. So I stop you, prevent water from. And then I measure urine volume and osmolarity every hour, and measure the serum osmolarity every 2 hours. So if I find after inhibiting you from drinking water and find urine osmolarity more than 600, what's your diagnosis here?
Urine osmolality more than 600.
Yeah.
So that means it incorrect. So if it incorrect, it can be diabetes insipidus. So it can be either central or nephrogenic.
No, this is this is a primary polydipsia.
No, you said, okay, say it one more.
Yeah,
The
because
urine osmolality
so if you have
got more dilute.
No, urine osmolarity
Say it.
get more than 600, which means it's more like it has more more solubles, like more molecules inside it. So the osmolarity increase after stopping water. That means the kidney is working. So the cause of hyponatremia here is due to drinking a lot of water.
Polydipsia. Okay.
Okay, so it's primary.
So it becomes more concentrated. Okay.
Yes.
Okay.
How
Okay.
about if it did not get concentrated, like if it's less than 600? So what should you do right now?
You give them desmopressin, right?
Yeah, first you continue if the urine osmolarity is stable on 2 to 3 consecutive hourly measurement and the plasma aldosterone more than 295 and the plasma sodium more than 145, then you give them desmopressin and then you monitor urine osmolarity and volume every 30 minutes for 2 hours. So after desmopressin, if the urine osmolarity increased, what is that?
So urine osmolality get more concentrated. Is that what you're asking me? I want to make sure that I know what you're saying.
Yeah.
So if it now gets more concentrated, that means that is a central.
Central diabetes insipidus. What if it decreased? small or no change in urine osmolarity.
Nephrogenic.
Yeah, this is nephrogenic diabetes insipidus. Okay. Now, if you are a 72-year-old male who have shortness of breath and fatigue, okay, and hypertension, so when I gave you nitroprusside, you had flushing, altered mental status, arrhythmia. We had this question before. It's a cyanide poisoning.
Okay.
Yeah, they ask that a lot, like 2 times on the step 2 and 1 time in step 3.
Oh, really? Like the real test?
No, in the question bank.
Oh, okay. I was like the real test. Yes.
Yeah. So now, if you are a 32-year-old male who had a left flank pain, hematuria, and vomiting, and
Left flank pain.
and you have a Crohn's disease, so what's the mechanism of renal stone in Crohn's disease? That's a
Oh
tricky one
man.
too.
Okay, I think it has something to do with the oxalate. Increase reabsorption of the oxalate, which can now go to cause
Yeah,
calcium oxalate stone.
yeah. In Crohn's disease, you have a
Yeah,
problem in absorbing the
with the
fat. Yeah, the soluble. So the calcium, the vitamin D, I think it was attached with calcium. So you will absorb more oxalate. Yeah, so that's what causes, and the oxalate goes to the kidney and causes stone. So if you are a 40-year-old male,
48. That one more question. That's it.
yeah, 40. If you are a 40-year-old male, when I do kidney biopsy, I found dense deposit within the glomerular basement membrane. So what type of kidney problem is that?
Dense deposit
Yeah, and
in where?
immunofluorescence shows positive for C3. You have 4 plus proteinuria and lower extremity edema, dark urine. But what gives it away is a dense deposit within the glomerular basement membrane.
Dense deposit. So this is nephrotic. Okay.
Yeah, which one?
4 plus. Yeah, that's what I'm trying to. I know that focal will be those. Is it? No, not membranous. Um, dense. Membranous.
It's the membranoproliferative glomerulonephritis type 2.
Membranoproliferative.
Yeah, this is
Okay.
how they describe it. They have C3 nephrotic factor and dense deposit in the glomerular basement membrane. It's caused by activation of the alternate complement pathway. So sometimes they ask it in this way, by activation of the
Okay.
alternative complement pathway, okay? So that's how it is.
Okay.
Okay, so this last question. Okay, so now let's, do you want a rapid revision of what we discussed for today?
Yeah, go ahead and be. Let me see. Let me
Yeah, I'm just
log
gonna
in
do
on my phone.
really quick revision. Yeah, just because this is gonna consolidate it really well.
Okay, I'll just be listening.
Okay, yeah, I'll be talking on the phone. You can mute. If you can, could you mute yourself? Okay. Hello? Okay, so now the rapid revision. Okay, if you have frequency urgency dysuria with a negative urinalysis, that's a painful bladder syndrome. If you have the bicarbonate is low, that's a metabolic acidosis. If you have both serum and urine osmolarity low, that's a primary polydipsia. Lithium causes increase in increase in serum osmolarity and decrease in urine osmolarity. Diabetes causes glomerular hyperfiltration. When you have heart failure, I'll transfuse you even if your hemoglobin is 7.5. But if you have acute coronary syndrome, I'll transfuse you even if your hemoglobin 8.5. Loop diuretic can cause metabolic alkalosis. So you know that by increasing bicarbonate level after you give diuretic. The treatment of cystitis and uncomplicated, you give them Bactrim. If it's complicated, you give them fluoroquinolone. Ethylene glycol causes envelope shaped crystal on urinalysis. Cocaine causes rhabdomyolysis. Hyperkalemia changes. First, you have tall P wave, prolonged PR on QRS, drop in loss of P wave. SLE present with sinus infection, sunburn, and decreased complement. The management of hypernatremia by IV fluid. Hypertension with the flank masses, that's a PKD. The management of metabolic alkalosis by IV fluid. If you have needle-shaped crystals on urinalysis, then you gotta do CT of the abdomen for uric acid stone. The drugs that causes hyperkalemia is digoxin, heparin, non-steroidal, and succinylcholine. Naproxen can cause tubular interstitial nephritis. RBC cast, this means glomerular damage, while just RBCs mean non-glomerular damage. Lymphoma and non-steroidal can cause minimal change disease even in elderly. Acute oliguria, you diagnose it by bladder scan, and then if there is retention, you do cath. The management of hyperkalemia by diuretic and calcium gluconate. Crystal-induced acute kidney injury caused by cyclovir, sulfonamide, methotrexate, ethylene glycol, protease inhibitor. If you have a dense deposit on pacemaker membrane disease, that's most likely membrane proliferative glomerulonephritis caused by activation of the alternative pathway of the complement system. Okay, and that's a summary of the discussion for today. I couldn't do all the questions because I don't know, my throat stopped working. Okay, so I'll see you guys tomorrow at 1:45 CST and 2:45 EST. Do you guys have any questions, concerns?